So before the break, we were looking at care guidance, and now we're going to look at how to manage the psychological environment around living with DMD, how to talk to your children, your loved ones, and each other. To offer some advice on these issues, we're joined by Dr. Rory Conn, who's a paediatric psychiatrist at the Devon Partnership Trust in Exeter.
Good afternoon, everyone. I send apologies from my colleague Chloe, who is in Paris presenting something else to do with Duchenne, but we've collaborated on the slides, and I hope I do her bit justice. So, I love this project. I've worked on lots of things in the NHS, and the passion from the people who've set up and contribute to the Duchenne community is fantastic, and that's why I went to the interview in the first place to take up this role. So, a lot of what I'm going to talk about is about stories, and it's only fair if I tell you a little bit about me first. I'm a child psychiatrist, and I work in liaison psychiatry, which is the interface of physical and mental health. And that's why this project appealed to me, because Duchenne is as much a neuropsychiatric disorder as it is a muscle disorder. And it just happens that I also have a rare medical condition, genetic condition, and some of you may have heard me speak before, so I'm just going to tell you a little bit about that. I have osteogenesis imperfecta, brittle bones disease, and it hasn't had a major impact on my life, is the truth, but both of my children have inherited it from me. And I want you to know that because I know a little bit about talking to children about a genetic disorder which has been, in my case, inherited from me. And I won't dwell on that, but I also know what it's like to have bisphosphonate infusions. I have zolendronate, and so does my son, who has regular infusions. So I know how horrible that can be. And I'm going to draw a little bit, I suppose, on my experience of having conversations with my kids, if that's all right. I'm not going to talk about my career and stuff, but you can look at my website. Please do, because I've blogged quite a lot about, not Duchenne so much as the interface of body and mind. And in particular, there's a blog there you might be interested in about diagnosis and medication within CAMS, Child and Adolescent Mental Health Services. And that's my Twitter handle, X, of course, now. So, I think I used this slide in the interview, actually, when I was thinking about what I would like to achieve from this project as I understood what was key. And that's about, first and foremost, improving the knowledge and confidence of the North Star sites to recognise mental health problems and psychosocial stresses in children. I'm a child psychiatrist, so I'm involved in the under 17.5 bit of this project. Thinking about what screening tools might be helpful to recognise the difference between an anxiety disorder and repetitive behaviour seen in autism, for example. But probably most importantly, helping, and we can't do this on our own, but improve the timely access that you as families might get to mental health support, which we all read newspapers, we all know is a major issue. And ultimately, to reduce the rates of mental ill health in the Duchenne community, and that applies to carers and parents as well as the lads. So I won't speak about what Chloe's done. She's done tons more than me. I do 1 day a week, and I've done 1.5 years, I think, now through this 3-year project. And I haven't actually seen huge numbers of boys, and I may get to meet some of you and your families along the way. But there's been quite a lot of consultative work, and what I mean by that is teams coming to me as a psychiatrist and saying, we don't know quite what to make of this. Should we be worried about this? Is there a treatment for this? And I run a monthly surgery on a Friday morning. We've had 9 of those now, where teams bring dilemmas and questions and themes. So we had one where we spoke for a whole hour about sexuality in boys with Duchenne. That was very interesting. We've had one dad's group online, and that would be great if we could do some more of those. That was very interesting. But also I've been trying to get the word out there and presenting in various forums where there are paediatricians with an interest in this kind of work, because our project is only 3 years and can only achieve a certain amount. And it's like with everything, you need to give the knowledge to other people to make things better. So the background to the psychosocial part, this is, may not be able to quite read that, but percentage dissatisfied with care. And you can see psychosocial, a huge spike there from this survey. Almost half of families saying we're not happy with this level of care that we're getting. And specifically, I pulled out from that this quite stark fact that discussions around mental health were happening very little. And hopefully over the last year, this is starting to build up a bit of steam, but fewer than 10% of patients and families saying that mental health was addressed. So here I am to help you address that. And no mental health screening tools were being used, and we want to change that. This is an image from the medical assessment. I don't know how many of you have seen the North Star actual paperwork. This is a part that's about steroid effects, and there is this one drop-down bit about behavioural changes, yes, no, moderate, severe, etc. And that clearly doesn't have the level of depth that we need in terms of assessing functioning in your lads. And I think there's quite a lot of pitfalls that we can have from the point of view of the child or the young adult. And this doesn't get spoken to, I think, but your boys may be thinking these sorts of things about themselves, consciously or otherwise. I'm naughty, I can't do it, I'm stupid, my brain doesn't work. And we need to try and find ways to have conversations with our patients about that to address it, and to try and find the hope and optimism that will prevent depressive illnesses developing and so on. But also I think that professionals, and I know my colleagues are guilty of this, because I've had conversations that go like this, we can't really fix that because this is the Duchenne. And I've had conversations with CAMS teams who say, well, we don't know anything about Duchenne, that seems too complicated, we couldn't possibly help. And actually part of this project has been saying that the sort of issues that boys with Duchenne present with are actually the same kind of issues that other young people have. Anxiety, low mood. And whilst the genetic basis might be different, or we might know a bit more about it, doesn't mean the treatments are any different. So it shouldn't preclude, for example, if a diagnosis of ADHD has been made, access to psychotropic medications like stimulants, because my CAMS colleagues should feel able to prescribe alongside the input from people like John as the cardiologist giving the all clear for that. I can't introduce you to everyone in the project, but it wouldn't be fair unless we had this image here. That's a year ago now, isn't it? But a really great team of people who are thinking long and hard about how to do this sort of work. So what is psychosocial care? I think yesterday we decided we don't like the term at all. And for lots of young people, it might really put them off. So I think we might need to jig that around a bit. But it's a term that's been recognised in the standards of care as being something that's been rather neglected. And it's an important way of encapsulating the fact that this isn't just medical. So sometimes we talk about the biopsychosocial model. And in the pink there at the top, we're thinking about all the biological stuff that we've been talking about so on today. And then there is the social and the psychological aspect. So this is thinking about boys with Duchenne and men with Duchenne. How are they doing with their learning, with their socializing, with their friendships? What is home life like for them and for you? And what are the impacts of those things? And those are huge. Those are just as important as making sure you get the best cardiac care. And of course, they're interlinked as well. But I think it's really important that our patients with Duchenne, your boys, know that the focus isn't just on their illness, it's on them, and they need to be at the centre of care. They need to understand that their voice is being heard, despite the fact they might find it very difficult to speak, either physically or psychologically, which we'll come back to. So again, there's an argument to say that the needs of families of people with Duchenne are actually much the same, because yes, the development will be different from the perspective of physical development, but psychologically, a teenager with Duchenne should be able and expected to be a teenager, to be angry and irritable and grumpy and dismissive and difficult to get out of bed in the morning and all those sorts of things. So I guess part of my role as well is to recognise when something sounds like normal adolescence, for example, and to remind the clinical teams and perhaps you guys as well, that's probably all right, everyone is dealing with that, but also to recognise when it goes beyond that or when it slips into something different. And why would you want a psychiatrist involved? Well, apart from the diagnosis, which you do need a doctor for, of various mental illnesses and disorders, you might also want to be considering medication. And I don't think today is a talk that's going to really go into medication. It's a bit beyond what I want to do today. So where do we start? I want to just think about how complex Duchenne is, and there are many people here who know an awful lot more than I do about Duchenne, but also how we can sort of simplify it. And this is going to lead on to how to have conversations with young people about it. So I know a little bit. Before this project, I really knew very little about Duchenne. And now I know that the DP140 is more implicated in autism, I think that's right, and that everyone has the DP427 issue. But actually, if we're talking about, if we remove the complexities of the image on the left, we can talk with boys about the fact this is a really complex gene, and there are different varieties of variation that can cause different effects. And actually, with an image like that, we can say there's areas that can affect people's brain and their thinking, and there are areas and deletion effects that can affect the body and the muscles. That seem reasonable? And I think it's important that we don't flood children with too much complex information when we can do it a bit simpler. I don't want anyone to try and read this text, but this is a really nice metaphor, I think, of what we find in Duchenne. So one of the aspects about psychiatry that people find either interesting or infuriating is that we don't have specific things like blood tests. So we rely on our opinion and also the adding up of symptoms and then some judgment as to whether this is or isn't something. Quite different maybe to other aspects of medicine. And the model at the top is a bucket that could represent me. And all of these different coloured balls might represent areas that one might have weakness in, okay? And the bottom black line, that's sort of the lid of this biscuit tin, might be the line we would call diagnostic significance, clinical significance. So if you have enough of the balls that cross that line, then you might get a diagnosis of something from me. And that's all very well if the young person or the adult is like the bottom left image, where there's sort of one main problem, and it goes over the diagnostic level, and you get your diagnosis and your treatment. So, for example, a child I might see in CAMS who has OCD, just OCD. The picture we often see in Duchenne, I'm afraid, is much more complicated. This is a broad neurodevelopmental disorder, and often families will come hoping for a range of investigations to find something that then can have a label that will be helpful. And often investigations will show, gosh, there's a whole host of difficulties here. Speech-language sort of problems, concentration difficulties, and actually maybe we test all of those and we find none of them quite reach significance. That can be a problem for things like EHCPs, education and healthcare plans, but it's also an argument to say this is a child who's going to need more support, not less. So part of our project is going to be advocating for you guys and your kids about what you can expect to receive. Hopefully, for example, all young people getting cognitive testing at the point of starting school or at the point of diagnosis, whichever is first. But also recognition that you don't require a diagnosis in order to get the right support. You need a formulation, which is a description of the problems as a whole. I hope that makes sense. So we will champion that for you and hopefully push it forwards. You're going to recognize this description, I think. This describes the child who has Duchenne, who has a range of problems with their communication, a lack of flexibility, a sense of frustration about the world, and perhaps some anxiety that makes them need to do things in certain ways over certain periods of time. And if things go wrong, they get very upset. They don't recognize this sort of pattern? Some hands going up. It's not the case for all of you, and some may be thinking, oh no, my lad's not quite like most of those things. But this is typical of a description we might get in a referral. Put up your hand, please, if you've had a cognitive test for your child, just as a quick survey for me. So about 6, goodness me. Say again? If you are a sibling. Yes, good point. Yes, thank you, I take that. But I wasn't surprised to see very few people have had cognitive testing done on their family member. When we do them, they're very helpful because what they do is not just an IQ test. I mean, overall it is something called a WISC is what would normally be done for under 16s. It will show areas of strength as well as weakness. And hopefully you'll all recognise with the family member you have with Duchenne that there are some areas that probably he's really, really good at or really likes and gets quite fixated on. And hooray, we need people who can be rather fixated on things. But there are common areas of weakness. And we need schools to be able to recognise what these areas are in order to adapt around the child. And we need families and we need clinicians to be able to adapt around these things as well. So this is going to take some time to get this level of assessment going. But again, it's a longer-term focus of the project. Working memory is something really important to think about. And I have had requests and referrals thinking about, well, could this be ADHD? So this is what commonly happens in a classroom. I'm not going to read it out, but this is what a teacher might sort of say. And for some children, that's fine, and they can do all of those things and come back to square one. But it's pretty bewildering if you're struggling to manage your working memory, to hold on to tasks and jumble them around and see them through. And boys with Duchenne tend to therefore need quite a lot of patience. They often need things presenting visually, and they need repetition. So again, schools need to know that, and you guys need to know that as parents as well. I think I meant to put this slide towards the start, but I just want to, this is nice it's here now, actually. So you're not alone. You understand this is a really wonderful community. But I also want you to know that there are other examples of rare disease, not only osteogenesis imperfecta, the one that I've got, but other things and other parents who've been through really very challenging times. And there's quite a lot of good info out there, really, to kind of rely on. But you're the experts on your child. So until the point that I meet your child, I know nothing about them. I know what their mutation is, maybe, and what school they go to and who else is in the family, but that might be about it. You're the expert on your child, and if you are getting information or instruction from the teams looking after your child, which you know is not going to work, please feel able to say that, and the same with school, etc. So how do you have discussions with your kid? I mean, I think probably for lots of you, you might tell me that the most difficult discussion you ever had was hearing about the diagnosis yourself, and there'll be many stories about how that was delivered, and maybe it was done well, maybe it was done badly. And then maybe the second most difficult discussion in your mind, if you haven't had it already, is with your child. This case study was from about a year or so ago, and a child who's having quite sudden onset difficulties with a question about what was driving it. And it was because he'd looked up about Duchenne and read some things that he'd not been told about. And he had a lot of questions about what was wrong with him and a sense of sort of secretness about that, hence the sleep problems. Couldn't switch off from it, was very worried about it. This is a really common story, and you don't need a psychiatrist to help with that, actually. I won't try and regenerate what David Schoenfeld's written in a really fantastic book chapter that covers this topic exactly, but I want to bring some ideas for you. So when to do it? As soon as possible, basically. And if you're holding back, wonder whether you're holding back for yourself, or because someone hasn't given you permission to do it, or because your child doesn't want you to do it, or says they don't want you to do it. But there is no perfect time to have the conversation. It's also never too late to start something you think maybe you should have started before. Children are very perceptive, and they will see if you're looking wobbly about having a conversation. And if they think it's off limits, they won't go there spontaneously themselves. So they need to know that it's a safe space, and that it's not that you can't bear to talk about it, even if that is what you're feeling, which would be normal as well. So sometimes young people, whether it's Duchenne or otherwise, will pretend they don't know as well, in some sort of folie à deux would be the psychiatric term, sort of everyone sort of pretending or deluded that something isn't happening. I think the information has to come firsthand, really. It's best done in person, not online. Yes, reading some things as well, but it's got to be face-to-face, really. But it's normal for a child's understanding with anything to progress in a linear fashion. That's good. So the earlier you start and the more you do things in a drip-feeding fashion, the best. And I would advise you to avoid flooding your child, giving them too much information in one go, even if you feel like you're on a roll, nor starving, nor thinking, well, actually, probably they should only know this amount now. Because if they're asking you the questions now, that's probably the time to cover it. If you feel you don't know the answer, they need to know that you don't know, but there's a plan about how you're going to find out more. I.e., well, we've got an appointment coming up next month. Let's write down some of these questions together so we can make sure that we ask them of the expert team. It's quite hard to know how much information is too much, and I mean that for you guys as well, because there's a lot of forums out there, and one could fall down a bit of a rabbit hole of reading a lot of stuff about genetics without necessarily understanding it and actually overloading oneself as well as one's child. But every pet child is different, and your boy might want to know as much as possible, and that's probably okay as long as there are people around to support. They'll need repetition, and you'll need to check on their understanding at appropriate times, and that might look like something like this. Did you have any more questions about what we discussed yesterday? They may not have retained it. I'm happy to go at it over again. And also suggesting a time that might be helpful. So when would you like to talk about it? You know, on Saturday night, we're having the movie and pizza night, aren't we? So would it be good to do it just before that so we've got something nice to do immediately afterwards? And that association with something positive, with something perhaps worrying, is okay. It makes it a bit more manageable. Knowledge brings power, or at least a sense of control. But you'll worry about the can of worms. So if you start talking about things like heart failure, then a bright young lad is going to say, well, if my heart doesn't work, then I'm going to die. And then do you find yourself having a conversation about death before you've even started the rest of it? This is really complicated, isn't it? But with the internet, the questions are going to be there and the answers are there much more immediately. This is as much for the North Star sites, I think, but information needs to be 4 or 5 A's, available, accurate, accessible, and age-appropriate. So there's some really good stuff out there. Lots of it is done in metaphors, and there are pros and cons to this, because if you're a literal black and white sort of person, and someone tells you about shock absorbers, you might start to visualize this in your thighs. This is absolutely what happens, and then kids can get really quite preoccupied about what's going on in their muscle. So dystrophin being the shock absorber of the muscle, great, that can be a really helpful analogy, but only if you're checking that the child has understood that. Hopefully lots of you have come across the Mission Duchenne comic. I really like it. I've recommended it several times. And it's, you know, it's gentle and it's appropriate and it's positive. And there's also really good animation, the brain pop animation. Has anyone seen that? I don't have time to show it now, but just Google it if you haven't. So again, how much information should they know? You guys are starting to learn lots about genetics, and is that appropriate for them to know? Well, again, there's some good resources about how do you explain genetic disorders to young people. And they may have heard what a deletion is, a genetic deletion. I really like this graphic here that shows if you take something out of a sentence, it doesn't make as much sense as it should. And maybe that's enough for them to know if they've got a basic understanding of how the genes might be read in the body. And this is quite helpful to show how long the dystrophin gene is and how, if you've got a certain bit missing, that can be challenging. If I get to meet boys with Duchenne, I might go into a bit more detail, especially if they're really bright, and I might talk about areas of the brain like the amygdala, which we know is the fight, flight, freeze area of the brain, and how dystrophin is expressed in the amygdala. And I don't have time to explain this analogy, but the fire alarm part of the brain ultimately is what the amygdala does. And if that's firing off, that will leave all of us feeling anxious. And sometimes it's empowering for a young person to be able to visualize, okay, there's a bit of my brain that it's not my fault, but it's kind of firing off more than it should, and what are we going to do about that? This is what I hope will go into the guidelines. Came up this late last night, a night, it just sort of popped into my head, and I quite liked it, so I wrote it down immediately. I want boys, when they're coming for their Duchenne reviews, for the team around them to be asking themselves these questions. What do they need to know at this stage in their development? What are they able to understand? What do they want to know? And that needs to be a direct question to the child and the family. Are you ready for this? And also, what are you guys willing to discuss? Because the truth is, if as parents you're not ready and you're shutting it down, clinicians might get a little bit at loggerheads, or at least, quietly a bit frustrated with one another. This is actually written by the paediatrician I work with in Exeter, Dr. Tomlinson. I think he's captured it quite well. There's no single way in which these conversations can happen, but the most complex bits are probably done when they are able to take on the significance, perhaps in adolescence. But it's not okay to dump lots of information when they're not ready. You probably won't be able to read this, but another thing we want to introduce to clinic, because it's hard when young people and adults are put on the spot and asked things directly face-to-face, we know that, is the opportunity for them to write down some thoughts and feelings in advance. So I'm hoping over the coming months we might, if we keep badgering the North Star sites, get them to keep piloting this questionnaire. I've condensed it. There's not just one line to write on. But it says, what's going well for you at the minute? What questions do you have? Is there anything that's worrying you? And if you come to clinic armed with some thoughts that your son has written, this helps offer a springboard for the conversation. Given that in that appointment there has to be covered tons of other stuff about mobility, cardiac function, etc. But it would be very easy for this stuff to be neglected, basically. And this is an example of how it worked well. So this was a lad I saw through the project. He was able to write this down for me prior to the assessment. Actually, I think he was writing it for his parents, really. But it was very good articulation. And I think actually if this had happened in the appointment, that question had been asked, this quality of answer wouldn't have come. How long have I got? I'm fine. I've got too much to say, I think that's the thing. I want to introduce the idea of alexithymia. So this relates to speech-language difficulties. In medicine, A usually means the absence of. Lexi, like lexicon, is words. And thymia means mood state. So it's very, very common in Duchenne for boys to lack the ability to find words for their feelings. That's called alexithymia. You can go away and Google it, and there's some quite helpful strategies out there to manage that. So you know your lads the best, but beware the kind of pursuit of questions around feelings, because they might find it very difficult. This is also why CBT might be really quite challenging. You know, the normal therapy for anxiety disorders in kids, CBT, might be very challenging for boys with Duchenne. But they might write something down for you. They might tolerate quite a lot of silence in order that they can process and produce an answer that is meaningful. Again, I'm talking as much to the professionals, my colleagues in the room here, actually, as parents. But you can reflect back what you can see, and I do this in not just in Duchenne work, but all the time in CAMS, and I offer hypotheses which I'm happy to be shot down on. You know, you do look worried to me, but I may be misreading that. Is that the case? Is there something that you're concerned about? It's fine to use. Two ideas of things that are very straightforward, especially if your lad is into numbers. So if they don't have words for feelings, they might prefer to do numbers. And how I would ask this as the clinician is not only, well, let's try and come up with a score for life and how things are going and how we're feeling, but also if it's number X, what might need to be different for it to become something higher than that, and what's stopping it being lower than that. So that's my way of understanding what the protective factors are. So you're not 0, you're 4, because actually there's 4 or 5 things that are going really well, but also what might need to change. The Aladdin question I've been using for years, the problem is that lots of young kids now haven't seen Aladdin. It's a bit sad, really. But the idea is not what would you have, because if it was my son, he'd want to own Tottenham Hotspur probably. What would you change about your life to make things better? And it's fantasy, you know, it can be anything. I'd get rid of Duchenne. Yeah, of course, good. But let's talk about that. Let's talk about why you want rid of this horrible disease. But what else? And you know, you might really be surprised what they come up with as numbers 2 and 3. And actually, let's encourage it to be 5 or 10 things that I'd like to change. It might be I'd like a new haircut because all my mates are getting that, but you know, we're not able to go to the hairdresser, or you keep saying no to a short back and sides. And actually, those are good things to know about, because you can impact the psychological health through other ways. Okay, so why expect anxiety? I just want to talk about that because that's probably the principal issue, really. firstly, the lack of psychoeducation, so boys not knowing, not being forewarned and forearmed about what the problem is, and then also understanding that things like reduced life expectancy are scary, really. How will I cope? Will I be a burden on my family? And lots of your sons will be, if they're of a given age, be thinking about this even if they're not articulating it. But also, I've mentioned the amygdala, and I'm not the mice expert, so I won't even try. But we do know that essentially the brain in DMD is primed to experience anxiety more. And that is a real kick in the teeth, isn't it? Because it's a horrible illness anyway, and it's just another whammy on top. There's some research going on into this, which is great, and you can do a bit more reading. This is a slide I give from other talks. What about the fact that actually anxiety rates are increasing in young people generally anyway? And let's not forget the fact that there's stuff going on. This is now 10 years. I've been giving talks about anxiety in kids for 10 years. That's from January 2014. Young people feel they have nothing to live for. And it's normal for adolescents to be feeling a real sense of dis-ease anyway. We've got climate change. We've got schools that are crumbling down with that horrible material that doesn't do anything. We've got global wars escalating. So it might be that your lad is worried about stuff that's nothing to do with Duchenne. And having the conversations about what else is going on is also very important. COVID, that's another one. Goodness me. The impact of that on young people has been really dramatic. And not least in things like language development and socialization. So given that there's language difficulties in about 50%, 10 minutes, thanks, 50% of boys with Duchenne, alongside ADHD probably in about 20, autism in about 10%. It's hard to know, actually, but there's been other stuff going on. So I wonder anyway if the new normal for lots of young people is a state of uncertainty and a lack of control and conflict. So I don't want this to be too miserable, so I'll skip on from that now. So families are systems, and I want you to think about how you support yourself and each other. That analogy of you put on your own gas mask first, oxygen mask, is a really important one. So this is seriously stressful. Is it not, parenting a child with a rare genetic condition where there is so much unpredictability? And again, I can identify with the feelings of worrying about things like fractures. And I want you guys to know that if you are feeling that you're struggling, then it's good to get that looked at sooner rather than later. And that might not be that you have developed a depressive illness, but it might be that you would benefit from some counselling, some psychological therapy. So please reach out, because that is the best way of helping your child to make sure you are in the best psychological position. Touching briefly on the kind of screening tools that we might use when we get referrals, the RCADS, the Revised Children's Anxiety and Depression Scale, is something that I've been using in clinic with boys with Duchenne, but sorry, you won't be able to read that probably. There are some questions here that are problematic. I feel like I don't want to move. That's not great. I think about death. Okay, it's relevant, but some of the work with the BIND study is thinking about what better screeners might be applicable. So we're not there yet, but in the meantime, we would be using the kind of screening tools that CAMS understand. So if I want your lad to be referred on to CAMS, having got some data from something like an RCAD screening tool is really helpful, so they can take that forward. It then puts into a data set and you get a nice graph, which is quite helpful to look at. And that one specifically is from the same lad that had written about the stuff he was worried about. Separation anxiety being extremely common in lads with Duchenne from what I've seen, and panic symptoms for the obvious kind of reasons. How do we support siblings? It's a whole other talk, really, but I think recognising that siblings have individual mind states. There will be a sense of denial, not wanting to ask, not wanting to burden a parent by being another child who might be worried about stuff. But also siblings often take up a kind of caring role, or they might act out in a way that they start sort of being difficult, whether or not they have Duchenne themselves. And they can feel rather isolated, deceived, vulnerable in their own way. It's probably because they haven't got the understanding of Duchenne. So when you're doing this psychoeducation, not a good word, for your lad, please incorporate the siblings in that, because maybe everyone needs to understand it in the same way at the same time. Okay, so back to the fact that you are the expert. So you're going to come to your reviews hoping for expertise, but please know that we as clinicians need to understand your child through their lens. They need to have space and time to talk, and particularly healthy if there can be time in the reviews for them to be on their own, but also to hear your narrative. So sometimes that looks like writing, a single A4 page of bullet points before clinic. My colleagues are going to shoot me here because they've got so much to do. But here are our concerns. And actually, as a clinician, you see that before the family come into the room. It's really very helpful because it tees up some important conversations. So please feel free to do that. Emotions are complex things, and we all have them, and the more that we can talk about them, the better. I can't remember what else I was going to say about that particular slide. But this is just a whole range of them, and this is normal, and to be angry is totally appropriate. So embrace that, actually, because it's good. It's good to be angry about something that's really shitty. I think that's important. Forgive my language. So I think we're almost there. I haven't actually talked about the project, so part of my role as a psychiatrist is to be consulted to by all of the different sites. I may end up seeing some of you in a clinical context. We invite the sites to make clinical referrals to us. I'm based in Exeter, so if we meet, it would be online. But I think I'd say from the outset, it's not about me reducing my workload, but I'm probably not the first person you need to see if your child is anxious. And there will be local evidence-based interventions to help your child with anxiety. We just need to plug them into them appropriately. And the chances are your lad is probably not going to hugely want to engage with me online. Unless the child has developed really very severe symptoms, something like psychosis from steroids, which is very unusual, or a really severe depressive episode, you probably don't need me, you probably don't need medication. We can help with things like advancing questions around, does your child have ADHD, might they have autism, but we can't do the complexities of those assessments online. So the project longevity is going to be to help these things to happen locally, and I hope you can understand that. And if a referral comes to me and I say that's not appropriate, that's not because I don't want to help, it's because I want to help you in the longer term with plugging you into local services. Last two slides are about the other bits of the project. Sorry, forgive me. This is not good behaviour to skip through, is it? Emotions thermometers are very helpful. Sibling project. So if you're interested in that side of things, if there's a sibling who's struggling, or you think, would it be interesting for us to know more about sibling stuff, then Rosie is the person to contact, I believe, about that. Rosie's here. So please take that email address down. And this is another project thinking about parent psychoeducation. So in the process of being developed, let's look at how we can improve this, and Andrea is the contact for that one. I don't know if there's time for questions, one or two, but I think I'll stop.
Can you go back to the previous slide with the sibling?
Yeah.
Can you share the slides afterwards?
Yes, I'm very happy for them to be circulated. Be surprised if there isn't a question. I'd be disappointed. Yes. Might need a mic. You just shout.
Where do I need to run?
I don't need the microphone. That would be really loud.
Okay. I'll just shout.
Yeah.
I'll stand up so you can hear me. Just a correction. Thank you very much, because I find your speeches really, really interesting. Oh, okay. So I find them very interesting, and they're very much where we're at the moment with our son. What would you suggest we do? We have asked his neuromuscular consultant to refer to your project about 8-9 months ago. He's also on the list for CAMS. He's also on the waiting list for Addenbrooke's Hospital Psychological Department. He is experiencing anxiety. He it has come off his feet recently. So he's going to that non-ambulant stage. He's also year 6 going into year 7. So we're at a real stage where we've written it into his EHCP. We really want him to have support, but he's on a lot of lists. How do we advance that?
Okay, so it sounds like, to have another metaphor, there's lots of cooks, but no one's coming to the kitchen. There may be some other resources you could use. There's good stuff online like Kooth. Has anyone used Kooth? Which is a free intervention online that does kind of low intervention CBT stuff for kids. Because some of this will be about Duchenne and some of it's not. So look up the sort of increasing numbers of free online provisions. I would definitely want, if there are significant anxiety issues, a local CAMS team to be involved, but thresholds are very high, unfortunately. It's good you've got paediatric psychology locally. I think that's the one I would push for, because whilst paed psychology operate on service levels agreements, SLAs, and they'll say, well, we've got the budget and the go-ahead to do cancer and cystic fibrosis, most of them will offer a generic waiting list. And there will be a wait, but they really understand the body-mind stuff and how it is for a young person to live with a chronic condition. So I think they would probably be best placed. In the meantime, just carry on doing the best that you are doing to try and listen and nurture and recognise for your lad that it's horrible to wait.
Rory, thanks. Excellent talk there. I think it's important for parents and professionals to understand that we do know about the high risks of learning and behaviour problems in Duchenne muscular dystrophy. There's quite extensive research. Actually, Janet's talking about that tomorrow, which is, if people want to know more. I think one of the big problems, certainly that I face in supporting parents and going into schools, is that people, other professionals in particular, don't see the difficulties through Duchenne glasses, if you see what I mean. That they don't kind of unpick what the problems really are. And so that doesn't get translated, for example, into education, health and care plans, and resources provision doesn't follow that. So I think it's really important that for parents to try, I'm not suggesting you become a psychiatrist, but well, you could do. But I really encourage parents to try and get a handle on it to some extent, so you can begin to ask the right questions in meetings and so on, and not accept badly written education, health and care plans which don't provide the right assessments or the right sort of quality of provision.
I agree with all of that, and yes, we need to see things through specific lenses of understanding, and at the same time, I do worry about things being so specific that other professionals just say we don't get it. So it's kind of a both-and position. But start asking now for things like cognitive testing. Why is it that we've not had that done? Because we hear from the Duchenne community that's really important. And then as our drive is coming out, you'll be in a stronger position to sort of see that through, I think.
Can I just ask? Yeah, go ahead. What I see as a professional, and I've been a professional for many, many years in Duchenne, is that we're talking about the boys, and what we need is more help for parents. There is nothing, we talk about the neuromuscular service, there is nothing more devastating for parents, particularly when the boys are on a downward slide, to come to clinic when they know the boys are getting worse, but to hear it in numbers. And I have had parent after parent who's got upset about these awful assessments because they've gone down, because they can see things. And we all know the boys are going down, but it's when they come to clinic and they're told things are getting worse. Your heart function's getting worse. Your breathing's getting worse. Your sleep study was worse. And I think we're lucky. I'm at GOS. We've got a brilliant family therapist. She's totally overstressed. But I think it's no good just talking about boys. I really, really feel that one of our big gaps is help for parents.
Yes, I agree, and that might help, I hope.
Not giving a presentation, but it is on the sibling study, because one thing that I've really struggled with is to get support for my younger son. And just a top tip, I know hospices sound like a really scary place, but a lot of them do have sibling support programs, because we went to our GP and we were told that CAMS, the waiting list was years for James to be seen. But if you can do something to help us, take part in this project. There's only ever been 2 studies looking at the impact on siblings, and they were done donkeys years ago. If we can collect this data, we can present this to regulators, to NICE, to explain the impact that Duchenne has on the whole family. So it is a really useful thing you can do. So.
Thanks, Alex. Thanks, Dr. Conn. I feel like, again, there's much more we could talk about here, but we're going to move on now from